Okay.
This is off topic, but for the reference 47, it's not letting me up. It don't let me upload anything to that Gradebook.
I don't know why. I'm so
I can email it to you.
I'm so frustrated with Brightspace
Yeah, I don't-
and the uploads and it's so frustrating.
Yeah.
And especially specifically with this class, because this class has so many homework items, and it truly is a ridiculous amount. I mean, every time I log into Brightspace, I have like 50 to 100 things to grade, and I'm like, no, I don't wanna. So you think you hate doing it? I also hate doing it. Okay. Yeah.
You said it's this is on the shows.
Oh, I didn't see that part. Resubmit it. I'm sorry, I didn't see that. Okay. Okay. That reminds me, everyone that is going at least I added you guys to AceMap. And if you are not if search in your email. If you emailed Kara Roby with all of your immunizations, it should be in your sent email. So that's what I need you to download up into AceMap so that I can approve all of this so that you can go to clinical. Okay. Like I said, without it, you cannot go. It is to your Ross email. It's from AceMap. It's not from me.
So, all of our medical stuff, is that gonna be uploaded by somebody else or I have?
No, ma'am, that is, nobody can upload anything to AceMap other than you. Well, that's what I'm saying. If you gave it to her, she has the copies. If you emailed it to her, it's in your email from you, like in your sent email. It's on, you don't have to do fit testing. Okay, so you have to make your profile for AceMap and then go in and upload all of your stuff. Okay. It has to be. I know I add I'll have to check later. But I know for a fact that I added each and every one of you to your OB clinical. Okay. Let's get through these chapters so that we can review. Please do not start working on that worksheet now because I don't want you to miss lecture. I would rather you pay attention to what I'm saying and do the worksheet later afterwards than do it right now. Okay. So, chapter 56 is Introduction to the GI System. I would hope that we're all pretty familiar with the GI system. It starts with the mouth, tongue, we have salivary glands, parotid gland. The digestion begins in the mouth. We have actual like special enzymes in our saliva that start to break down food the moment that it touches our mouth. Okay. The epiglottis, it's a little flap that covers your trachea so that you don't aspirate food and liquid into your lungs. And then we have the pharynx, larynx. Also, you have your esophagus. They are two tubes that run parallel to each other. That's why it is so imperative to make sure that your patient is actually capable of swallowing. Do a swallow test, bedside swallow study, before you give any pills or food or anything like that. Okay. Our liver metabolizes, obviously. Your stomach aids in digestion with hydrochloric acid, and has peristalsis, which means it has movement and waves to digest the food and churn the food. Through the after the stomach goes the duodenum. The duodenum is where a lot of nutrients is absorbed from the food. And our food gets turned into what is called chyme, which is a really yucky, gross substance. And then it goes through the small intestine to the large intestine, to the rectum, and out of the body. We also have the gallbladder and pancreas. The pancreas, obviously, we talked about in endocrine, is responsible for insulin production from the islets of Langerhans and the beta cells. You also have your gallbladder, which stores bile. And bile is what's it called? An exocrine, which means it's not supposed to be within your body. It needs to be, bile is, oh my God, come on, brain. Bile is toxic to your body. So if you, like, say you have a perforated gallbladder, that becomes kind of an emergent situation because the enzymes in that bile can actually break down the tissues within your body. So it's important that they have to go in, remove that gallbladder, clean it all out. So that you can digest. But we can live without a gallbladder. Now, granted, people that do have their gallbladder removed usually do have GI issues, and they usually have to run to the bathroom about half hour after they eat anything, which sucks. But at least they're not constipated and they have regular bowel habits. We already talked about this. Okay, so layers of the GI tract. You have your mucosal layer, submucosal layer. This is on page 1009, where it talks about the different layers of the intestines. Muscularis external layer, serosal layer, enteric nervous system. And this is where the sympathetic and parasympathetic influence on the GI tract. So your rest and digest or fight or flight. That's where it affects your GI tract. And there's a nice little picture that's in your book also. So the activities of the GI system is to secrete enzymes, acid, bicarb, and mucus. It aids in the digestion of food into usable and absorbable components. Then you have the absorption of water and almost all of your essential nutrients needed by the body. So this happens all throughout the small and large intestine. Most of the water absorption happens within the large intestine. I want you to remember the longer stool stays in your colon, the less hydrated it becomes. So if you do not have regular bowel movements and your stool stays within your colon for an extended period of time, the harder it is for that stool to pass. Okay? And when we talk about laxatives, we'll talk about how it influences the stool during constipation to exit the body. We talked about last week or the week before when we were talking about the pancreas. We were talking about how the stomach stores hydrochloric acid, right? Which aids in digestion of your food. Can hydrochloric acid go into your duodenum?
No.
No. So the pancreas actually secretes sodium bicarbonate into the duodenum to neutralize the acid, okay? Because that hydrochloric acid would burn the crap out of your small intestine and duodenum. So there has to be some type of mechanism that neutralizes that acid before it hits your intestines. And your pancreas is takes on that role, is responsible for that. So compounds secreted in the GI tract, you have saliva, which we discussed. There's enzymes in your saliva that aids in digestion of food. There's mucus, acid and digestive enzymes, which include gastrin and hydrochloric acid. Ghrelin and secretin are hormones that affect your hunger and satiation. Sodium bicarbonate, we already talked about, comes from your pancreas to neutralize the acid. You have pancreatic enzymes, lipases, and amylases. These aid in digestion. We have to have these enzymes to digest our food, okay? If your patient has pancreatic issues or acute pancreatitis, you'll notice that they take a drug called Creon before every meal, and we're going to talk about Creon, that it has to be taken before every meal because it contains those enzymes that they're lacking because of the acute pancreatitis, okay? Then you have your bile and your endocrine hormones, which we went over previously. I don't want to talk about that. Okay, so digestion is the process of breaking food into usable, absorbable nutrients. It begins in the mouth with enzymes in the saliva. The stomach continues the digestion process with muscular churning and acid and enzymes. So it works in both ways. When we talk about gastroparesis, we talked about that last week when we were talking about the GLP-1s and the risk for gastroparesis. It's the paralysis of your stomach. So when you don't have that muscular churning, gastric emptying does not occur. So not only do you have to have acid and enzymes to break down the food, but you also have to have that muscular churning to move the food through the digestive tract. And then in the small intestine, bile breaks down fat and molecules. So for absorption, it is the active process of removing water, nutrients, and other elements from the GI tract and deliver them to the bloodstream for use in the body. So like I said, this happens within the small intestine and the large intestine. The portal system drains all of the lower GI. So when we talk about the word portal refers to the liver. Delivers what is absorbed into the venous system directly into the liver. So the portal system connects the intestines to the liver, okay? The liver filters, cleans, and then further processes most of what's absorbed before delivery to the body. So first it goes into the mouth, then down the esophagus, into the stomach where acid and enzymes break down the food. You have muscular churning that occurs. It goes into the small intestine where it is neutralized by the pancreas with sodium bicarbonate. It is then moved through the small intestine, through the large intestine, and throughout that process, the portal system takes nutrients and water from that food and delivers it to the liver where it's filtered and then spread throughout the body. And most absorption occurs within the small intestine. Motility, the GI tract depends on an inherent motility to keep things moving. This is called peristalsis. Peristalsis. The nerve plexus maintains this movement and the basic movement in the esophagus and the intestines, not just the esophagus is peristalsis. The point of peristalsis is that is a movement down. It stops things from going back up. Okay. So peristalsis is the movement of things going down, down, down. Okay. The stomach uses its 3 layers to produce churning and action. The small intestine uses the process of segmentation with occasional peristaltic waves. So the esophagus, every time you eat something, there's peristalsis, okay? When the food enters the intestines, the peristalsis is a little bit different. It's a little bit slower. It comes in waves like the ocean, okay? So it's not just like a constant movement. It's a wave and then a relax and a wave and then relax. So when you have GI upset and you have abdominal cramping where things are like really trying to get out of your body and you have that really bad pain, that is really intense peristaltic movement that causes that pain, okay? The large intestine uses the process of mass movement with occasional peristaltic wave, and the rectal distension after mass movement stimulates defecation reflex. So when we talked about the bladder, we talked about or stretch receptors, that when the bladder wall feels that stretch, that's what tells your brain, hey, I need to empty my bladder. It's the same thing within the rectum, okay? Stool doesn't always stay within the rectum. The rectum should be an empty space, all right? And it should only have stool in it when you are ready to defecate. So stool moves through the sigmoid colon down into the rectum, and that stretch receptor within the rectum says, hey, there's something in here, let's go poop, okay? Local gastrointestinal reflexes. No, that's a really big word, Carly. My brain's not working at that great at the moment to answer that question. Local gastrointestinal reflexes, you have your gastroenteric reflex. This is the, Bentall. We'll talk about it later. This is the stimulation of the stomach by stretching, presence of food or cephalic stimulation, and it causes increase in activity of small intestine. So you have to think everything that happens in your digestive system prepares the next step of your digestive system. So food enters my mouth, I start to salivate, okay? That tells my esophagus, hey, something's coming. My esophagus tells my stomach, hey, something's coming by having those peristaltic waves. Once food is in my stomach, the stimulation of that gastroenteric reflex says, hey, small intestine, you better ramp up because I'm sending stuff your way, okay? So it has to be a constant movement of activity for the reflexes to occur. So you have your gastrocolic reflex, which is the stimulation of the stomach, and it causes increased activity in the colon. Your duodenal colic reflex is triggered by the presence of food or stretch in the duodenum, which stimulates the colon activity and mass movement. So everything stimulates the next step. I am not really going to, do I want to? No, I don't. Central reflexes, we have our swallowing reflex, which is stimulated when a food bolus stimulates pressure receptors in the back of the throat and pharynx. I want you to think about, when you think about these reflexes, think about a baby, okay? When a baby is born, nobody has to tell that baby or teach that baby how to swallow. It is a normal reflex. As soon as that baby feels something in their mouth stimulating those pressure receptors, the baby automatically swallows. It's the same thing with breathing. It's the same thing with blinking, right? These are central reflexes, which means nothing, the brain is like, hey, you need to do this. It's later in life, these things become voluntary, where we can do it on a voluntary or involuntary basis. But at the core of everything, at that moment that you're born, we are born with these reflexes. Okay. So then you have your vomiting reflex. This protects the system from unwanted irritants. It's stimulated by the two centers in the medulla, which is the emetic zone and the chemoreceptor trigger zone. I need you to know what triggers the CTZ. The chemoreceptor trigger zone is the CTZ. I need you to know what triggers the CTZ, which is on this slide. Stimulation of the CTZ. So you have tactile stimulation of the back of the throat, which is, when you stick your fingers in the back of your throat and you play with your little uvula and then boom, you start gagging and vomiting. That's tactile stimulation of the back of the throat. Excessive stomach distension, when your stomach is too full. I learned this very early on in my gastric sleeve journey, that if I eat too much, you better guess it's coming right back up. Okay, because there is no more stretch. There's no more room for the food. So it's coming right back up. So you eat too much, the stomach becomes too distended, it will evacuate that food from your body. Increasing intracranial pressure by direct stimulation. So vomiting, especially vomiting without nausea, is a huge indication of increased ICP, which we're going to talk about in a couple months. Stimulation of the vestibular receptors in the inner ear. This is when you're dizzy and you have vertigo, or you're on a cruise ship or a boat, and all of a sudden you're like, oh, I'm gonna yak. This is the vestibular receptors in your inner ear. Stimulation of stretch receptors in the uterus and bladder. I don't know about you guys, but I absolutely vomited during labor. I don't know why. Now I do know why, because it stimulated my CTZ. It did only happen once. And granted, they were flipping me all over the place. I was on my knees, I was on my back, and then all of a sudden I'm like, I'm gonna yak. And it was terrible. Okay. That's why they don't let you eat when you're in active labor. Also for risk of surgery and C-section. But anyways. Intense pain fiber stimulation. When you are in a severe amount of pain, this can absolutely trigger a vomiting episode. And then direct stimulation by various chemicals, specifically one that induces vomiting called Ipecac. It is a real thing. It was a real thing definitely back in the day. It does still exist. It's just not given very often unless we need someone to really vomit. True or false? When the renal capsule becomes irritated, the gastrointestinal tract shuts down. I don't even know the answer to that. That's a silly question. Let's see. It is true. Oh, because we didn't talk about the reflexes because I didn't care about them. I'm just being very honest with you. I don't need you to know the reflexes. I really don't. And honestly, I don't think the reflexes are in your ATI book. So if they are, you can correct me later. And that is the end of chapter 50. All right, chapter 57, drugs that are affecting the GI system. So, I'm sorry, drugs affecting GI secretions. Okay, underlying causes of GI disorders, you have dietary excess, which means you're eating a lot of stuff you're not supposed to be eating. Or, that could also include intolerances. So you're eating a lot of fatty fried foods, or you are lactose intolerant, or celiac. Okay. You could have stress. A lot of people have diarrhea when they have a stressful situation in their life. A hiatal hernia can increase your risk for GERD, which is gastroesophageal reflux disease. And then peptic ulcer disease, and then adverse drug effects. Pretty much every drug that we talk about causes GI issues, nausea, vomiting, diarrhea, or constipation. So GERD and ulcer disease. There are drugs used to affect GI secretions that decrease GI secretory activity, block the action of GI secretions, or form protective coverings on the GI lining to prevent erosion from GI secretions. Those drug classes include H2 agonists, antacids, PPIs, which are proton pump inhibitors, gastrointestinal protectants, and prostaglandins. On page 1017, under therapeutic actions and indications for H2 antagonist, it says H2 receptor sites are also found in the heart, and high levels of these drugs can produce cardiac arrhythmias. I have that highlighted.
Can you just maybe say that like one more time?
On page 1017, H2 receptor sites are also found in the heart, and high levels of these drugs can produce cardiac arrhythmias.
Thank you.
So your H2 antagonist, these block the release of hydrochloric acid in response to gastrin. These drugs include cimetidine, famotidine, nizatidine, a lot of nitidines, ranitidine, which was Zantac, which was taken off the market. So your most common drug, I feel like Zantac is back. I feel like that's not up to date. I feel like Zantac made a comeback, but I'm honestly not sure.
I feel like you're right.
I feel like I am right.
I think I've seen it.
Yeah. So your most common medications on this list, I mean, we've all seen them. You can buy Pepcid AC and Zantac over the counter. You cannot buy cimetidine, at least I don't think, over the counter. And cimetidine has a lot of adverse effects. So the therapeutic actions, it selectively blocks H2 receptors and prevents about 70% of hydrochloric acid release and decreases pepsin production. Pepsin is another enzyme in the digestive system. So your indications for H2 antagonists, short term. I'm going to say it one more time. Short-term treatment of active duodenal ulcer or benign gastric ulcer. You do not want to take these drugs for a long period of time. Okay? They have adverse effects, especially with long-term use, but also it could be masking other diseases or symptoms that can lead to diagnosis for that other disease process. They could also be used for the treatment of pathological hypersecretory conditions such as Zollinger-Ellison syndrome, prophylaxis of ulcers induced by stress or NSAID use, and acute upper GI bleeding in critical patients. So it's extremely important that we protect our stomachs from ulcers. So prophylaxis is a huge part of healthcare within the hospital system because any acute infection or hospitalization causes stress on the body. That's why every single patient you see in the hospital is on some type of GI prophylaxis, whether it's pantoprazole, omeprazole, which pantoprazole is also Protonix, or some type of GI protectant, okay? These are also used in the treatment of erosive GERD, treatment of ulcers caused by H. pylori. Remember on your key points, I told you I wanted you to know what H. pylori is and the treatment of it. And then the relief of symptoms of heartburn and indigestion. So the pharmacokinetics vary by specific drug. They cross the placenta and enter human milk. You want to use caution in pregnancy or lactation, hepatic or renal dysfunction, and you do not want to use for a prolonged or continual use unless the benefit outweighs the risk. Adverse effects are listed on page 1023. The adverse effects most commonly associated with H2 antagonists include GI effects of diarrhea or constipation, CNS effects of dizziness, headache, somnolence, confusion, or even hallucinations thought to be related to the possible H2 receptor effects in the CNS. Cardiac arrhythmias and hypotension related to H2 cardiac receptor blocking and more commonly seen with IV or IM administration with prolonged use. There's also a risk for gynecomastia with long-term use of cimetidine and impotence. So I would know those. This is just taking a closer look at cimetidine. It's for short-term treatment of active duodenal or benign gastric ulcers and all kinds of other things. It inhibits the action of histamine at H2 receptor sites of the stomach, inhibiting gastric acid secretion and reducing total pepsin output. The adverse effects include dizziness, confusion, headache, somnolence, cardiac arrhythmias, cardiac arrest, diarrhea, impotence, gynecomastia, and rash. I believe those are pretty important. Which H2 inhibitor is available in both oral and parenteral forms? The list of drugs is on page 1020 in table 57.1. The answer is famotidine. It is available in oral and parenteral forms. Cimetidine and nizatidine are available only in oral form, and lansoprazole is a PPI. It is not an H2 antagonist. Any questions on H2 antagonist? Beautiful. Okay, antacids. These are a group of inorganic chemicals that neutralize stomach acid. They are available over the counter. Many people use them to What? Oh, I don't know. Many people use them to self-treat a variety of symptoms. These drugs include sodium bicarbonate, calcium carbonate, magnesium salts, and aluminum salts. They neutralize the stomach acid by direct chemical reaction. They have symptomatic relief of upset stomach associated with hyperacidity. And the relief of symptoms associated with hyperactivity, as in peptic ulcer and gastritis. Believe me, if you've ever had gastritis or a gastric ulcer, it is painful and not fun. So you want to use caution in any condition that can be exacerbated by electrolyte or acid-base imbalance. Where do you have a high amount of acid? In your stomach. So if you neutralize all of that acid a lot, what do you think could happen to your acid-base balance? You could go farther into the alkalotic side. which is also the reason if you have a patient that is vomiting excessively, they are also at a risk for alkalosis because they're literally vomiting out all of their acid. Okay? Put that in your back pocket. Electrolyte imbalance, specifically calcium and magnesium, especially, and sodium, because they are literally made of sodium, calcium, and magnesium. So if you take an excessive amount of them, you could have an electrolyte imbalance. GI obstruction, renal dysfunction, and pregnancy and lactation. Fun fact, and many of you probably don't know this. I never knew this until I taught this class in August. How many of us have had heartburn during pregnancy and took Tums like they were Skittles? Yeah. Guess what you're supposed to do when you take Tums? You're supposed to drink 8 ounces of water when you take Tums. Did you know that? I did not know that. So we've all been taking Tums the wrong way this entire time.
Well, they
Drinking
work
8 ounces.
just fine anyway.
Well, apparently, drinking 8 ounces of water with your Tums makes it work significantly better. And I'm just mad about it because I had terrible heartburn and I did not take it correctly. Adverse effects are related to their effects on acid base and electrolyte balance. Rebound acidity with frequent use. I put this on your key points. What is rebound acidity?
Like if you stop taking it, then or suddenly maybe, then you get that acidity, like it comes back more fierce.
Amen, sister. So on page 1025, under pharmacokinetics, it says the main drawbacks to this agent are constipation and acid rebound, in which the stomach increases acid release in response to low acid. Acid rebound can occur in response to using antacids that decrease acid. Let's see. Magnesium salts are effective in buffering acid in the stomach, but have been known to cause diarrhea. They are sometimes used as laxatives. Aluminum salts available in tablets, capsules, suspensions, and liquid do not cause acid rebound, but are not very effective in neutralizing acid. They are bound in the feces for excretion. And they have been related to severe constipation. Okay, so I have a couple stars on my paper. The first one is limit use to short-term relief due to rebound hyperacidity, electrolyte imbalances, and they can mask serious GI conditions. Most of us, hopefully all of us, know that when women have cardiac conditions, specifically MIs, they usually present with oh my God, indigestion, heartburn. Okay. So there are a lot of instances where a woman goes to the ER and she's had persistent indigestion for the last 2 weeks. And guess what? She's having an active MI because they present differently in women. I don't know why. Don't ask me. Someday I should probably look that up, but I do not know why. So you don't want to take these and then possibly mask symptoms of a greater issue. Okay. Also, avoid taking with iron supplements to prevent decreased absorption. I've told you this many times. You pretty much never want to take antacids with another drug. They will decrease the absorption for probably 99% of drugs out there. I'm not going to say all because there's always a variable. And then again, take Tums with a full glass of water for proper dissolution and effectiveness. That's from my notes. It's in here somewhere, but it's in my notes that I just have stored. Um, so this is just taking a closer look at sodium bicarbonate. Adverse effects include gastric rupture, systemic alkalosis, which could present as headache, nausea, irritability, weakness, tetany, and confusion. Hypokalemia, secondary to intracellular shifting of potassium. If you take in a lot of sodium, it is going to disrupt your sodium and potassium balance. And also gastric acid rebound. Any questions about antacids? Okay, we are moving on to PPIs. PPIs end in prazole, omeprazole. Sorry. So your most common medications here are going to be definitely omeprazole, which is Prilosec, esomeprazole, which is Nexium, lansoprazole, which is Prevacid, and pantoprazole, which is Protonix. Pantoprazole Protonix is going to be your most commonly prescribed medication in the hospital. Almost everyone is on Protonix. So the therapeutic action, it specifically inhibits the hydrogen. Remember, what did I tell you to think about when we thought about hydrogen?
It's a base.
Acid. It is not a base. I need you to correct that in your brain right now.
Uh-oh.
Hydrogen.
Okay.
She said, uh-oh. Hydrogen has a direct correlation with acid. Acidosis. Direct correlation. Hydrogen and acid are basically the same thing. I need you to remember that now and forever, especially when you get to complex care. Okay. Also, the potassium paste enzyme system in the secretory surface of the gastric parietal cells. It's a very fancy way of saying that it blocks the final step of acid production. Okay. So if it's blocking hydrogen, that means it's blocking acid. And then it's also blocking that final step of acid production. Again, short-term treatment of active duodenal ulcers, GERD, erosive esophagitis, and benign active gastric disease. Can they be used long-term? Yes. Should they be used long-term? No. If they have to be, it's because the risk, the benefit outweighs the risk, okay? And then this can be maintenance therapy for erosive esophagitis and ulcers. Because if you remember in my lecture that I sent you, which was boring, thank you very much. Just kidding. I talked about erosive esophagitis and the fact that when you have cells that are constantly shedding and repairing itself over and over again faster than what it's meant to, it leads to a faster road to cancer, to cancerous cells. Okay? So it is more important to lower the risk for esophageal cancer by putting someone on these drugs long-term for long-term therapy than it is for the risk of the adverse effects of these drugs. Okay. These are rapidly absorbed from the GI tract, metabolized in the liver, and excreted in the urine. Contraindication would be obviously an allergy and then concurrent use with medications containing rilpivirine, which I actually don't know what that is. And it doesn't tell us in our book. Adverse effects are related to the effects on hydrogen and the potassium ATPase pump on the parietal and other cells. So it's related to the loss of acidity. You have CNS effects, GI effects, upper respiratory tract symptoms, other less common effects, and then long-term use could be increased bone loss and hypertension. The CNS effects include dizziness and headache that are occasionally seen. You also have asthenia, which is loss of strength. This is on page 1028. Vertigo, insomnia, apathy, dream abnormalities. Interesting. Upper respiratory tract symptoms include a cough, stuffy nose, hoarseness, and epistaxis, which is nosebleeds. Long-term use can also increase the incidence of C. diff and pneumonia. You have a couple drug-to-drug interactions when it comes to PPIs. You don't want to take them with benzos, phenytoin, or warfarin. Ketoconazole, which I covered in your other lecture, and I told you I wanted you to know things about ketoconazole. Theophylline, and then some antiretroviral medications. There's an increased risk of serum levels and increased toxicity of benzos, phenytoin, and warfarin if these are combined. So if you think about it, if you take these with benzos, then you have an increased risk for respiratory distress, respiratory depression, right? Because benzos are a downer, they are a sedative, okay? Phenytoin is for seizures. So if you are increasing and making it toxic, that could have, we haven't talked about phenytoin, but that could have its own serious effects. And then obviously, if we're increasing the levels of warfarin, that means that our INR is not therapeutic, which means that our patient is more at risk for bleeds, which means that's a huge safety situation, okay? For a patient that has increased risk for bleeding. Also can result in thrombocytopenia, which can have all kinds of side effects, including bleeding gums, easily bruising, GI bleeds, okay, petechiae. So this is just taking a closer look at omeprazole. It is used for the short-term treatment of active duodenal or active benign gastric ulcer, treatment of heartburn or symptoms of GERD, treatment of pathological hypersecretory syndromes, eradication of H. pylori infection as part of combination therapy. What is the zebra here in our adverse effects?
Vertigo.
Vertigo.
I just upper respiratory symptoms for sure.
The upper respiratory infection symptoms.
I say respiratory.
We can't
I think
hear
you're
you
frozen.
anymore.
We can't hear anything. Miss Simmons, you're breaking up really bad.
We can't hear.
Can you hear me?
We
Yeah,
can
you're
now.
back.
Yeah.
You cut
Now,
out right
but I
after
feel
you
like
asked
we
us what
might
the
have,
zebra was.
I didn't say anything else, so you didn't miss anything because I just was just watching the screen go like this.
Did you say what the zebra was?
Oh, that's why they kept saying it, like they didn't hear me. I'm like, guys, it's upper respiratory infection. Yes, you're correct. Yes, you're correct. And then everybody kept saying it over and over. I'm like, yeah, I know. You told me.
you started
So good.
breaking up right before you said what it was. So we were all like on the edge of our seat wondering what
That
was
is
it?
so funny. They're all just like, oh my God, what is she gonna say? I love that for us. Any questions about PPIs? I did not say anything else important, I promise. Okay. All right, let's finish this chapter and then we're going to take a break. So, GI protectant, there is only one. It is called sucralfate, also known as Carafate. It is a big white horse pill. That is hard to swallow. You can break them in half. They do have like a, what's it called, line, where you can break them and make it easier for your patient to swallow. So the therapeutic action is that it forms an ulcer adherent complex at duodenal ulcer sites. It's just a very fancy way of saying is that it literally coats the stomach. It coats the lining of the stomach. And it is very effective at doing so. So it provides a protective layer on the layer, like with inside the stomach wall. Okay, so this prevents further breakdown and promotes healing. It inhibits pepsin activity and gastric juices. I hate the word juices when they talk like this. It's gross. It is for the treatment of ulcers. It is minimally absorbed and excreted via feces. It is a small amount is absorbed, or I'm sorry, excreted in the urine. So it's very chalky. Even if you put it in a like little medicine cup with a little bit of water, it will disintegrate within a matter of like minutes, less than a couple minutes, and it's basically chalk. I mean, honestly, it's basically chalk. The one thing that I do want you to know about this is that it should be taken 1 hour before meals and at bedtime. And what really sucks, especially when you're providing care in the hospital, is it's really hard, especially when you're really busy and you have a 4, 5, 6 patient assignment, you're running around, you're giving insulin, you're doing all these things. It's really hard to time these things, especially when you don't know exactly when the meal is coming. If the patient is having food brought in from, their family or whatever. But it is important in the perfect NCLEX universe, in our perfect world, that it should be taken 1 hour before meals and at bedtime. Excuse me. The only contraindication, what's the med abbreviation before bed? AC and HS. AC is before meals, HS is before bed.
Think happy sleeping is before bed and AC is after chewing for breakfast.
I love that, but it's before meals. So it wouldn't be after chewing. I just don't want you to think after chewing and then think after meal. You know what I mean? But I do like the happy sleeping one.
All right,
Whatever-
just taking the HS part. Another one knows before meals.
Whatever works for you. Whatever works for you works for me. The only contraindication is renal failure. And then for adverse effects, you can have constipation, which is the most frequently seen. Other effects like dizziness, sleepiness, vertigo, skin rash, back pain, these are very uncommon. You do not want to take Carafate with aluminum salts. You also do not want to take Carafate with phenytoin, digoxin, warfarin, fluoroquinolone, antibiotics, or penicillin. And that is because They decrease serum levels and drug effectiveness. The individual agent should be administered separately with at least 2 hours between drugs. That's on page 1030 under drug to drug interactions.
So is that specifically for GI protectants?
That is specific for Carafate, yes.
Okay, thank you.
Mm-hmm. This is just taking a closer look at Carafate, which is the only drug within this classification. The other name is sucralfate. It forms an ulcer adherent complex at the duodenal ulcer site, protecting the sites from acid, bile salts, and pepsin, promoting healing of the ulcer, and also inhibits pepsin activity in the gastric juices. The adverse effects include sleepiness, dizziness, vertigo, insomnia, rash, constipation, diarrhea, nausea, indigestion, dry mouth, back pain. What is the most common that I just said with this medication? Constipation. Thank you. Somebody's listening back there. It's so a Monday. True or false? There is a drug-drug interaction between warfarin and sucralfate.
True.
That is very true. Sucralfate decreases serum levels and drug effectiveness. All right, prostaglandins. There's really only one drug in this category that I want you to know about. Well, there is only one drug, and that is misoprostol. Another word for this drug is called Cytotec. This is, if we are up to the times, this is the abortion pill. If you go online and you talk to an online provider and you're like, hey, I need to get rid of this pregnancy, they are going to send you misoprostol in the mail or from your pharmacy, okay? This is also the drug that they put inside of your vagina up close to your cervix to ripen your cervix to induce labor. Okay, that's all the same thing because it causes uterine contractions. So what is a contraindication to this drug? A fetus. Because you will lose this fetus if you take this drug. I need you to know that. Fetus deletus. That is correct, Marissa. And that really truly is the one thing that I need you to know about this. It aids in the prevention of NSAID-induced gastric ulcers in patients at high risk for complications. Why? Somebody give me the reason why. What happens in the inflammatory process, the inflammatory response? What gets released?
Histamine?
What else gets released?
Prostaglandins?
Ha! Prostaglandins. Prostaglandins is released. So, this drug aids in the prevention of NSAID-induced gastric ulcers. Okay? Because of its prostaglandin effects. Obviously, this is contraindicated in pregnancy. You want to use caution in lactation, hepatic, or renal impairment. You do not want to give this drug to a mother who is lactating and has just given birth to her baby unless the benefit outweighs the risk. Oh, hold on. So if you look under adverse effects, it says excessive bleeding or spotting, hypermenorrhea, dysmenorrhea, miscarriage. Okay. All right, digestive enzymes. Substances produced in the GI tract to break down foods into usable nutrients. There are two available. There's a saliva substitute and pancrelipase. Remember, I talked in the beginning about an hour ago about Creon. Okay, Creon is a drug for patients that have acute pancreatitis that do not have the enzyme production that they need to be able to aid in digestion, so they have to take Creon before meals. So the saliva substitute contains electrolytes and carboxymethylcellulose to act as a thickening agent in dry mouth conditions. It makes food bolus easier to swallow. I don't know, but that just gives me the ick. Like, do you put it in your mouth and then it like makes your mouth wet? Like, I don't know. I need to look into that because it makes me uncomfortable. Pancreatic enzymes are replacement enzymes that help the digestion of absorption of fats, proteins, and carbohydrates, and the indication is for replacement therapy. The saliva substitute does not generally, it's not absorbed systemically, it only works in the mouth, so it's local. The I'm just going to say Creon because I don't like that word, is thought to be processed through normal metabolic systems. The only contraindication is allergy. Caution with saliva substitute is heart failure, hypertension, or renal failure. Because there may be an abnormal absorption of electrolytes, including sodium, leading to increased cardiovascular load. Makes sense. So adverse effects, like we just said, the saliva substitute can have complications from abnormal electrolyte absorption. And then the Creon could have GI irritation, which could include nausea, abdominal cramps, and diarrhea. Which sucks because acute pancreatitis is painful enough. So this is taking a closer look at Creon. It is for the replacement therapy in patients with deficient exocrine pancreatic secretions. And the adverse effects are nausea, abdominal cramps, diarrhea, and uricosuriya. That's a word. So but it doesn't say anything about that under adverse effects in the book, only within this little tiny excerpt. All right, what H2 antagonist has been associated with anti-androgenic effects? What is androgenic? Testosterone. So what is the drug that has bad side effects for men? It is chimetidine. Chimetidine has been associated with anti-androgenic effects, including gynecomastia and galactorrhea, which, by the way, is breast milk in men. Also listed was impotence. Okay. And this is, I feel like this is a typical statement.
Miss Simmons, your sound is really weird. You sound like muffled.
Am I too far away? Can you hear me now?
No, you sound fine. Sorry.
Oh, I was sitting back in my chair, relaxing. That was my bad. And my voice isn't very projecting today.
Can you
but
repeat the last part about the gynecomastia?
Yeah, gynecomastia and galactorrhea, which is breast milk production in men. And another thing it listed was impotence. I was gonna say, I mean, it's kind of crappy to say, but men need to be told about these side effects. Okay, because when they experience these things where all of a sudden they are having growth in their breast tissue, they cannot keep an erection. Guess what that causes them to do? Stop taking the drug. They don't want to take drugs that they can't keep an erection with. Granted, if I had a penis, I probably wouldn't want to take drugs that took my erection away either. So, to be fair, I'm not judging. I'm just saying. All right, let's take 10 minutes. And we shall be back.
Miss Simmons,
Yeah.
no rush, but I emailed you my key points if you are able to just let me know if I'm in the right direction, kind of like you did last week.
He
If
said,
not, don't worry about it.
"Rush."
I'm not, I
Okay.
know you're sick and you got your own stuff going on. I just kind of
I will look at
No.
it later, okay?
perfect.
Oh,
Thank
I
you.
see it. She sent it 3 minutes ago, by the way. 3 minutes ago. I'm just kidding. I'm just messing with you. I promise. I'm just kidding.
If I go to this ASAP site, can I just make a thing? Or do I have to do it from like your email?
I'm pretty sure you have to do it from that email. Let me see. really need to get through this stuff. All right. Go ahead and share it. All right, so drugs affecting the GI motility. This is chapter 58. Can you close the door, please? So, actions of drugs used to affect motor activity or motility of the GI tract. They speed up or improve movement of intestinal contacts along GI tract when movement becomes slow or sluggish to allow for proper excretion of waste, which, if we don't have proper excretion, it leads to constipation. So they increase the tone of the GI tract and stimulate motility throughout the system. And then we also have the decreased movement along the GI tract when rapid movement decreases the time for absorption of nutrients, which is diarrhea. So we have drugs that make us poop and drugs that make us stop pooping. Okay, so laxatives, they are indicated for short-term relief of constipation. I want you to underline and star short-term relief of constipation to prevent straining, to evacuate bowel for diagnostic procedures, and to remove ingested poisons, and as adjunct for antihelminic activity, which if you noticed, I skipped over that chapter because I don't think we need to be learning about deworming humans. If you would like to go over that on your own, I beg you to do so. Bless you. But laxatives can aid in the help of removing worms from humans. Most available as over-the-counter preparations, and they have potential for overuse and dependency. Dependency meaning that when you use laxatives excessively, your intestines become dependent on the laxative stimulation. So without the laxative stimulation, the bowels do not work. And then you get what's called a paralytic ileus, which is a paralyzed intestine, which can lead to, if you're not very careful, can lead to death. There was a time where there was a famous singer, what was her name? Karen Carpenter. Karen Carpenter. She died because of excessive use of laxatives for weight loss. It's very dangerous. So we have different types of laxatives. I need you to know what the different types of laxatives are. So you have stimulant laxatives, which chemically irritate the lining of the GI tract, which stimulate movement. You have bulk forming agents that cause fecal matter to increase in bulk. Remember, the stretch receptors tell our brain that we need to go poop, and it causes movement in the body, right? So if you have a bulk forming laxative, it causes movement because of those stretch receptors. Then you have osmotic laxative, which are the most, which are like the safest type of laxative, which pull more solute and or water into the GI tract. With these, you have to watch for dehydration because it pulls the water from your body into the intestines. Because remember, the job of the intestines is to remove water from the stool. Osmotic laxatives cause the opposite to happen, where water gets put into the stool to soften it and have you go easier. Then you have lubricants, which help intestinal contents stay softer, more slippery, like mineral oil or castor oil. And then newer laxatives available for specific needs. They alter sodium absorption or affect opioid receptors in the GI tract, and they're not super popular yet. So, chemical stimulants, these include, they directly stimulate the nerve plexus, causing increased movement and stimulation of local reflexes. These drugs include bisacodyl, which is Dulcolax, castor oil, which is, it is generic, that's the generic name, and then Senna, which is also called Senocot. So these begin working at the beginning of the small intestine. They increase motility throughout the rest of the GI tract by stimulating the nerve plexus. And castor oil blocks absorption of fats. So the fattier the stool, the easier, and this is going to sound so gross, but the easier it literally is like slipping out. Like, so, and that's with the same thing with like a lubricant laxative, like mineral oil. Where you're increasing the lipids, causing it to evacuate easier. And then indications is for short-term treatment of constipation. I want you to realize that all of these, most of them say short-term treatment. Pharmacokinetics, most of these agents are only minimally absorbed and exert their therapeutic effects directly in the GI tract. But you're going to tell me, Jess, I don't understand. My patients in the hospital or my patients in the nursing home, they take these every day. I understand that. I really do. That doesn't mean that they should be, in the perfect NCLEX world, consumed on a short-term basis. Contraindication, includes acute abdominal disorders. This says castor oil for pregnancy, but you're like, hey, Jess, I took castor oil. Guess what you took it for? To induce labor. Okay. So it is contraindicated in pregnancy because it has a chance of inducing labor, which is why you don't take other laxatives while you're pregnant, because it can induce uterine contractions. Okay.
Miss
You do
Simmons, I
not,
have a question.
yeah.
Like when you say short term, is that like a week or?
I believe on the box of like stimulant laxatives, they say do not use for more than 7 days. I think they say that on the box or bottle or whatever. But it absolutely gives you a time frame for sure on the instructions. You want to use caution with heart block, coronary artery disease, acute abdominal pain, nausea or vomiting, pregnancy, and lactation. So I do have a star, and it is for, I want you to remember, avoid using regularly to prevent dependence. Okay, you do not want to be dependent on laxatives. Adverse effects include diarrhea, obviously, abdominal cramping, nausea. You could have dizziness, headache, weakness, sweating, palpitations, flushing, fainting, cathartic dependence, which is dependence on a stimulant laxative. Castor oil blocks the absorption of fats, which could include fat-soluble vitamins, which could lead to malnutrition. Remember, we were talking about bile acid sequestrants. Half of you guys got this question wrong. When something blocks or binds to the fat, it leads to a deficiency in fat-soluble vitamins, A, D, E, and K. It does not increase the absorption. Okay? It decreases, causing a deficiency. So this is taking a closer look at Senna. This is for the short-term treatment of constipation, and adverse effects, diarrhea, abdominal cramps, perianal irritation, dizziness, cathartic dependence, which is laxative dependence. Okay, bulk forming laxatives. These cause fecal matter to increase in bulk. They increase the motility of the GI tract by increasing the size of the fecal matter. It stimulates the stretch receptors, which we already talked about. These drugs include methylcellulose, which is Citracel, polycarbamyl, which is Fibricon, and psyllium, which is Metamucil. Would you want to take any of these drugs before you lay down and take a nap or go to bed?
No.
No, why?
You don't want to be running to the bathroom?
You're not
Nope.
gonna sleep?
Nope.
Does it have to do with laying down?
Yes. Huh? So you should not take these right before you go to bed or take a nap because when you lay down, it could cause an obstruction in your esophagus, could lead to aspiration because what is it doing? It's bulk forming. Okay. You want that stuff to go with gravity and go down. You don't want it going back up. Okay. And if it goes really farther up, it could cause an airway obstruction. Okay. It acts in a manner similar to dietary fiber. It's for the treatment of constipation, decreased diarrhea on patients with diverticulitis or IBS. And it directly is effective within the GI tract and can act rapidly. So these are one of the laxatives that it's safer to take more often because it is similar to dietary fiber, and fiber is good for our colon. It makes our colon happy. Contraindications include acute abdominal disorders, acute infections, intestinal obstruction, perforation, rectal bleeding, or healing from acute abdominal surgery. If you have just had acute abdominal surgery, would you want to add something that is causing bulking of your abdomen that could possibly perforate where your surgery just occurred? No, ma'am. Mm-mm. Ma'am and sir. I do have one sir in here. GI effects include nausea, abdominal cramping, diarrhea. CNS could be dizziness, headache, weakness, sweating, palpitations, flushing, fainting. Advise patients to take with plenty of water because it absorbs the water. That's how it bulks up, right? You should be drinking this in at least 8 ounces of water when you mix it in. Which, by the way, is difficult for old people when you're mixing their Metamucil and their Benefiber or whatever. It's difficult for them to drink that much fluid at one time. And they're already deficient usually because they have a decreased thirst reflex. So just a little something for you. Okay. Osmotic laxatives. They have solutes that increase the osmotic pool of fluid into the GI tract. So these include magnesium sulfate, magnesium citrate, which if you've ever taken magnesium citrate, that will ruin your whole day. Magnesium hydroxide, which is milk of magnesia, lactulose. Lactulose. We've heard of lactulose, yes? So lactulose binds that have chronic liver disease, hepatic cirrhosis, alcoholism, an increased amount of ammonia in their body. Okay, so most of the time that's what we know. That's what we know lactulose for, but it is actually also a laxative. So it's used in both ways. Polyethylene glycol, that is your Miralax. Polyethylene glycol electrolyte solution, that is Go Lightly. I don't know if anyone has ever seen Go Lightly, but it's a big, huge gallon of fluid that the patient has to drink as fast as possible. And they have to drink the whole thing, which sounds absolutely horrendous. So again, they draw water into the GI tract and stimulate increased GI motility for the treatment of constipation. And these drugs, especially like Miralax, they even say that is gentle enough to use daily, right? You can take Miralax, you can take milk of magnesia almost daily, and it doesn't really cause dependence because it's not stimulating the nerve plexus, it's just drawing water into the colon. So again, contraindications include acute surgical abdomen, fecal impaction, intestinal obstruction, because you don't want to be adding bulk to any of these situations. Lactulose with appendicitis, that I don't know where it is. It doesn't actually go into detail about it in the book. Oh, I'm sorry. All it says is also contraindicated in patients with appendicitis. Also lactulose with diabetes. I've never tasted lactulose, but I've given it a couple hundred times. And I will say everyone that I've given it to says that it's absolutely disgusting and it's extremely sweet. So, with a patient that's diabetic, you don't want to, it's like giving them a whole shot of pure sugar. It would increase their blood sugar. Oh, magnesium for renal insufficiency. You want to be careful because if your kidneys cannot excrete magnesium, you're putting your body at risk or your patient at risk for hypermagnesemia. Adverse effects are honestly the same as all of the other ones. Which drug is indicated for treatment of chronic idiopathic constipation? So which one is the only one that's safe to take long term? Even if you didn't know what chronic idiopathic constipation is.
D.
Miralax, only one that does not stimulate that nerve plexus and doesn't and is safe to take daily. Oh my God. How am I'm wrong. Oh my God. Oh geez. Okay. First of all, if Lactitol wasn't on that list, I would have been correct. Okay? Let me just say that right out front. I didn't realize when I looked at it that Lactitol was on there, which is why we should read the question entirely and all of its components. You see how easy that happens, even to me? So we learned two things today. That Lactitol is indicated for the treatment of chronic idiopathic constipation, but also that Miralax is not as short term as the other stimulants because the other ones affect the nerve plexus. Okay, moving on to lubricants. Lubricants make defecation easier without stimulating movement of the GI tract. It literally lubricates the intestines and lubricates the stool. It benefits patients with hemorrhoids who have had recent rectal surgery or who could be harmed by straining. I have never had hemorrhoid surgery, but I have been told that it is one of the most painful surgeries that you could have. And I don't know why. Maybe it's because you said, I don't know, but it is extremely painful. So the drugs include Docusate, which is Colace, which is a stool softener. By the way, it is literally soap, and so is glycerin. So have you heard of a soap suds enema? So it's because soap can be used as a lubricant. So there's a pharmacist on TikTok that actually does like things with drugs, and he put the Docusate Colace in water and let it dissolve and then shook it up, and it literally turned into like soapy bubbles. And then mineral oil, obviously oil is going to lubricate the stool.
Miss Simmons.
Yeah.
So I've never used it, but my husband has. Would Preparation H be like a lubricant?
Preparation H takes away the pain of hemorrhoids.
Okay.
Just like Tux pads. I remember them giving them to me after birth. So Preparation H, I believe it also can because hemorrhoids are so vascular, and they're sticking out, they're protruding, so they're extremely painful. And not only is it an analgesic, but I believe it also slows down the vasculation, decreases the red and angry, you know? Oh, here's the word I'm looking for. Vasoconstriction. Jesus. Goodness gracious. Vasoconstriction is the word I'm looking for. So anyways, Docusate is like a detergent. Like I said, it's practically soap. It irritates and lubricates. Glycerin, hyperosmolar laxative, gently evacuates rectum without systemic effects. And then mineral oil forms a slippery coating. Again, all of these, if not every single one of them, except for the only one I've ever heard that is safe for pregnancy is a glycerin suppository. That is the only thing that is safe for pregnancy. So you want to be extremely cautious with any laxative during pregnancy.
My grandma would make like an ivory suppository to help my daughter when she was constipated as a baby.
Yep, soap will do it for you. Soap will lube it all up, and it irritates, so it'll cause evacuation. And really, if you think about it, it's a lot safer than a lot of the other chemicals that you can give your kids, you know, because it's just basic soap and it's not being absorbed systemically. Adverse effects, of course, are going to be diarrhea, abdominal cramping, and nausea. Mineral oil leakage and staining. And I'm talking like literal anal leakage. Like, wear a pad. And then also, just like all the other ones, sweating, palpitations, flushing, and fainting. It is less likely with lubricant laxatives, though. Frequent use of mineral oil can interfere with the absorption of fat-soluble vitamins, which is A, D, E, and K. Opioid agonists. This is something, these are not used often, but they are a potential. I don't understand why they're not used more often, especially for patients that are experiencing opioid induced constipation. But they are possibilities. So they block the effects of opioids on the GI tract by selectively binding to peripheral opioid receptors. They can decrease the potential for pain relief, which may be why they're not used a ton. But they are specifically for the treatment of opioid-induced constipation. I don't really need you to know a lot about these. Yeah. Probably the most important thing on this is to monitor patients for opioid withdrawal symptoms and monitor for GI perforation if abdominal pain is severe. That is across the board. Anytime your patient has severe abdominal pain and they are post-op or they have opioid-induced constipation or a history of constipation or C. diff or diverticulosis, severe abdominal pain, you should always evaluate for a GI perforation. Gastrointestinal stimulants. There, I put this medication specifically on your key points that I want you to look at. This is metoclopramide, which is called Reglan. It's a common medication in the hospital. More generalized GI stimulation results in overall increased GI activity. This is a drug that can help with gastroparesis because it helps food and aids in digestion and helps keeps things moving. Okay. So it stimulates the parasympathetic. What?
Can you repeat that, please? I'm sorry.
Oh, it's used for gastroparesis and helps things stay moving. It stimulates the parasympathetic activity within the GI tract. It increases GI secretions, motility, blocks dopamine receptors, makes GI cells more sensitive. It leads to increased GI activity and rapid movement of food through the upper GI tract, which is why it's used for gastroparesis. Oh my God, my throat's getting so irritated. This drug is contraindicated in a GI obstruction or perforation. If you have an obstruction or perforation, there is no drug that you really should be using, especially for obstruction. You should be doing bowel rest. That's why they put in an NG tube to decompress the stomach and rest the bowel. And then for perforation, the only choice for that is surgery. This is the most important thing that I want you to know about Reglan is that there is a black boxed warning for tardive dyskinesia. Tardive dyskinesia. You should have learned about this or will learn about this when you talk about psychiatric medication. Let's talk about it over here. So the adverse effects include a boxed warning of tardive dyskinesia. On page 1048, the symptoms of tardive dyskinesia are facial twitching, lip smacking, tongue protrusion. These can become permanent. I let that sink in. These can become permanent. If your patient starts to acutely exhibit any of these symptoms of tardive dyskinesia, the medication needs to be discontinued immediately.
I'm so sorry.
Sorry guys, it's Dr. Rowling. I had to steal Miss Simmons for just a quick second, so she has to reply to something for me. She'll be right back.
You want them to know.
Yeah. Oh no.
Just okay. It was important because she's ordering me food, and that's important. All right. So I need you to know that if your patient is acutely exhibiting any of these symptoms, that the drug has to be discontinued immediately, and then you have to notify a provider immediately. Drug-to-drug interactions include antipsychotic medications because it increases the risk for tardive dyskinesia. Okay. This is just taking a closer look at Reglan. The adverse effects I want you to see, it has restlessness, drowsiness, fatigue, extrapyramidal effects, Parkinson-like reactions, okay? Seizures, nausea, diarrhea. These are very, very important patient education and evaluation as a nurse. All right, questions about that? Okay, so now we have antidiarrheals. Your most common is going to be loperamide, which is Imodium AD. You also have bismuth salicylate, which is Pepto-Bismol. So obviously, if you have diarrhea, you know that it's coming out faster than anything you're putting in. So the key to stopping it is to take an antidiarrheal, which is going to slow the motility of the GI tract. So Pepto-Bismol has a direct action on the lining of the GI tract. Loperamide direct action on the muscles of the GI tract, so it stops that oh my god, peristalsis. It has relief of symptoms of acute and chronic diarrhea, reduction of number of discharge from ileostomies. Ileostomies versus colostomies are harder to manage because colostomies you can have like timed bowel movements. Like remember, usually people that have regular bowel movements, they usually occur during the same time of the day, every day or every other day or whatever. Ileostomies, there's really no control. You really have no control of the output. So it could be helpful with ileostomies if you have an event or something like that. I'm not gonna have a voice tomorrow. You want to use caution in pregnancy and lactation, history of GI obstruction, because once you've had an obstruction, you're at a higher risk of a obstruction occurring again. Diarrhea due to poisonings. If you have had poisonings and you have diarrhea, you need to get it out. Right? When you have a GI bug, you need to let that run its course. Not when in a severe situation, you need to call a provider. But if you just have a regular GI bug, you don't want to stop the diarrhea. You want to get that organism out of your body so it stops causing the symptoms. Fun fact, loperamide is actually a counted drug in the hospital now, which is ridiculous because if you take enough of them, you could have an opioid type of reaction where it can cause a euphoric effect and hallucinations, respiratory depression and sedation. So, but also can be extremely dangerous and cause a huge GI obstruction. IBS and chronic constipation drugs. I did not really go into detail with any of these drugs. So we're just going to kind of look for any zebras, which I really don't think there are many. Tegaserod, you don't want to give to women older than 65. It probably messes with their hormones or calcium or something. Let's see. Tegaseride is contraindicated in patients who experience MI, stroke, TIAs, or angina during treatment. It is associated with increased cardiovascular risk. This is on page 1055. Patients should be monitored for any worsening of depression and or suicidal thoughts or behaviors because they could worsen. And it says nothing about the age of
65 and over.
Adverse effects are always going to be important because that's where your patient education comes from. So especially the tegaserod and the prucalopride, new onset of depression and self-harm behaviors, that's a huge one. Huge, especially when it comes to NCLEX, ATI. Those are going to be your big patient education and evaluation situations. All right, why should laxatives be taken only on a short-term basis?
Is it B?
Okay.
The answer is B, to prevent cathartic dependence. Cathartic dependence can occur with the chronic use of laxatives, leading to a need for external stimuli for normal functioning of the GI tract. I need you to know that. I've talked about it a couple times already, so I need you to make sure you know that. Okay, antiemetic agents, these are drugs that stop you from vomiting. So one or more common and uncomfortable complaints. Vomiting is a complex reflex reaction to various stimuli, including the CTZ, which I told you I needed you to know. In many clinical conditions, the reflex reaction of vomiting is not beneficial in ridding the body of toxins. Instead, it is uncomfortable and even clinically hazardous. Antiemetics used to decrease or prevent nausea. Are we done at 1:30? I thought we were done at 12:30. I was like rushing through.
We're done at 1:30 today.
Honestly, I really would rather power through so that we could have time for our review, because I was literally panicking, thinking that we were gonna have to have our review as like a voluntary thing. So that because I can't tell you that you have to be there because it's not part of your scheduled hours. So it is up to you whether you are part of it or not, and whether that would occur today or tomorrow before your ATI exam. So
I rather push through as well.
yeah, I would rather. I mean, especially you guys at home, go get a snack and sit back down. It's you guys really here that are kind of stuck. So if you're hungry and you need like a couple minutes to go grab something, I also understand that. It's up to you. All right. I'm powering through. Okay. So emetics, this is like your Ipecac. This is an agent used to induce vomiting. It's no longer recommended for at-home poison control. That's why it was widely used at home back in the day. I don't even know if you can actually buy Ipecac over the counter anymore. I really don't think you can. Antiemetics, this is to decrease or prevent nausea and vomiting. Centrally acting or locally acting. Centrally acting means in the brain, those CTZ receptors, and then there's varying degrees of effectiveness. True or false, emetic medications are used to induce vomiting and should be kept in the home in case of accidental poisoning. That is false. Emetics are no longer recommended for at-home poison control. Call poison control. Okay, so groups of centrally acting antiemetics. You have phenothiazines, non-phenothiazines, serotonin receptor blockers, substance P, neurokinin 1 receptor antagonists, and then the miscellaneous group. Phenothiazines include the one that I need you to know about is promethazine. That is the generic name. The brand name is Phenergan. So the thing that I need you to know about promethazine is that it is a vesicant. It can cause severe tissue damage if it is extravasated, which means it is given IV. If that IV infiltrates and this drug gets pushed out to the soft tissue, it can cause severe tissue damage. Okay, that is very important. You need to make sure that your IV is patent. It needs to be flushed before you give any other medication. Okay? So these change the responsiveness or stimulation of the CTZ in the medulla. Promethazine is a histamine receptor blocker and has dopaminergic effects. Remember, histamine receptors are also within the heart, which is why they cause dopaminergic effects. Okay, so they can have an effect on your cardiovascular. You know what I'm saying? Contraindications would be a coma, severe central nervous system depression, brain damage, injury, severe hypotension or hypertension, which it leads to, remember, the histamine effects on your heart and your cardiovascular, and then severe liver dysfunction. You want to use caution in renal dysfunction, moderate liver impairment, active peptic ulcers, and then promethazine. We do not routinely give these to children or give that drug to children. Adverse effects include drowsiness, dizziness, weakness, tremors, headaches, hypotension, and cardiac arrhythmias because of the H2 antagonists. Extrapyramidal symptoms, which is your tardive dyskinesia. So make sure you are looking at promethazine and Phenergan. Non-phenothiazine, only one available. This is Reglan, which we literally just talked about. It blocks dopamine receptors and makes GI cells more sensitive to acetylcholine. It leads to increased GI activity and rapid movement of food through the upper GI tract. It's not routinely used for antiemetics. It's more routinely used for gastroparesis. So then you have your 5-HT3 receptor blockers, which is where your Zofran comes in. We all know on ondansetron or Zofran. So this blocks the receptors associated with nausea and vomiting in the CTZ and locally. It's indicated especially helpful in treating nausea and vomiting associated with anti-neoplastic chemotherapy and radiation therapy, postoperative nausea and vomiting. Let's see. Contraindications, we've talked about this. If you get this wrong, I will be mad at you. Ondansetron, Zofran is contraindicated in any patient that already has pre-existing long QT syndrome, prolonged QT syndrome. You do not want to give Zofran with other drugs that cause prolonged QT syndrome. Okay? Oh, Marissa, there are a laundry list of medications that cause Stevens-Johnson syndrome. I swear, I think it's the most common adverse effect in the world that's not common. Substance P, neurokinin 1 receptor antagonist. This is the newest class of drugs for treating nausea and vomiting. I do not have any stars on this classification of drugs, but it would be probably important to know. Oh, this would, okay. It is metabolized in the liver, excreted in the urine and feces. I would say the most important thing to know about this classification is that the adverse effects include neutropenia, anemia, and leukopenia, which is going to lead to immunocompensation and obviously anemia, which is a low red blood cell count, which can lead to hypoxia, and then all the symptoms that are involved with hypoxia. For drug-to-drug interactions, they do decrease the effectiveness of warfarin. There is a decrease in the effectiveness of hormonal contraceptives if they're taken concurrently, so a barrier contraceptive should be suggested. That would definitely be an important patient education aspect, not really for my exam, but more for an ATI standpoint. Miscellaneous drugs, you have dexamethasone, which is a steroid, specifically a glucocorticoid. It somehow works on the works as an antiemetic, and we don't really know why or how. But also remember, dexamethasone is a very strong hitting glucocorticoid steroid, and it's really not given out all willy-nilly. It's given for very specific indications. Scopolamine. What just happened? Oh, that's green with blank. Scopolamine, it is a patch, a transdermal patch that actually goes behind your ear, like right here on your neck. It has anticholinergic effects, just like oxybutynin, which the bladder antispasmodic has anticholinergic effects. So remember, they can have those effects like dry mouth, constipation. And then another one is Tygan. It's thought to decrease nerve signals in the vomiting center in the medulla. Tygan, I wouldn't say it's the most common, but it is given for antiemetics.
Meclizine.
That is true. And we didn't even, did I skip over meclizine? It's not even listed on here. Okay, the answer is meclizine. Meclizine, if you didn't know, it is, the other name for it is Antivert. It's given for vertigo, dizziness and vertigo specifically, which if you think of Antivert, it's, makes you kind of think of vertigo. But meclizine is indicated for relief of nausea and vomiting associated with motion sickness. Right, this one.
list the things that contraindicated with St. John's wort. Did anybody do that? So chapter 60 is vitamins, mineral, and complementary alternative medications. This one is short and sweet, but there are things that I do want you to know in this chapter. Specifically, those big common herbs that people take that they don't realize actually have an interaction with the medication that they take. Okay. So, defining vitamins and minerals. Vitamins are organic substances that are needed for growth and nutrition, typically not made by the body, therefore they must be consumed in the diet. Minerals are naturally occurring inorganic substances. Examples needed for health include calcium, phosphorus, potassium, chromium, copper, fluoride. We need all of these for proper growth and development. There are times when people may need additional supplements due to the lack in their diet or an increased need. Alternative medicine are products and practices for promoting health used in place of conventional medical care. Complementary medicine are products and practices for promoting health used together with conventional medicine. So it's complementary to each other. Integrative health encourages multimodal interventions, including both conventional and complementary approaches, focuses on improvement of health as opposed to treatment of disease. So these are really your holistic approaches. Alternative medicine is intended to be used in conjunction with conventional medicine. True or false? False. That is false. Alternative medicine is products and practices for promoting health used in place of conventional medical care. So when you see the term complementary, or what is the other one? Integrative, that means that they are used in combination with other things. So the U.S. Department of Agriculture and U.S. Department of Health and Human Services dietary guidelines follow a healthy dietary pattern at every life stage. Enjoy nutrient-dense foods and beverages that align with cultural traditions and budgetary constraints. Stay within calorie limits by eating foods that are nutrient-dense to meet all food requirements. And then limit or abstain from food and beverages with added sugar, saturated fat, high sodium, and alcohol. Pretty much saying, stop being a glutton, stop eating everything, and eat healthy, which is very difficult. Why does everything that tastes good have to be bad for you? Again, vitamins must be obtained from animal and vegetable tissues taken in as food. Most are only needed in small amounts, and they are either water soluble or fat soluble. We've discussed fat soluble vitamins so many times, and the deficiency and things that cause the deficiency of fat soluble vitamins. So with fat soluble vitamins, you need fat to be able to absorb them. That also means that you can become toxic when you can virtually overdose on fat soluble vitamins. Okay. So you want to be careful with your intake of vitamins A, D, E, and K, because if you overuse them, you will become symptomatic of too much in your system. With water-soluble vitamins, if you take too many, that's okay because they just come out in your pee. Okay? Minerals are also taken in via diet. Some are also electrolytes. Vitamin and mineral deficiencies can increase the risk of health problems. Therapeutic actions, many roles to facilitate functioning of the human body. They're used to build bones, make hormones, regulate fluid volume, generate nerve action potentials, produce red blood cells. Vitamins and minerals are essential. They are essential to a healthy human. Indications for dietary supplements is the treatment of deficiencies when people's normal diet doesn't meet those needs. So it's actually, if you are meeting all of your dietary needs, you shouldn't have to take supplements. But we do anyways. So contraindications would be when levels are normal or high in the body, especially when it comes to fat-soluble vitamins, because you can pretty much overdose on that. There are drug-to-drug interactions. Vitamin B6 and levodopa, you do not want to take them together. Fat-soluble vitamins and mineral oil, cholestyramine or cholestyramine, also the bile acid sequestrants, right? Because they bind to the fat. Some minerals and tetracyclines and other antibiotics and irons, you want to be careful. You don't want to take antibiotics. You don't want to take any drugs with your, which I know you're going to say, in the hospital, I give my patient a handful of pills and it includes their multivitamin. I know that. I know. But in real life, in NCLEX world, you should not take your multivitamins, your antacids, your vitamins and minerals with other drugs, okay? Which of the following vitamins is fat soluble? I can't see you. Hold on.
You're good. He is individually here replacing our internet boxes for the future. So we have 3 different boxes. So the internet it will kick out, but it will kick back onto another one. So he's individually replacing them. So we should have internet, but it's going to be glitchy.
Yay.
So
So I'm going to use my hotspot.
that's what I did.
Okay.
So, sorry, I just wanted to let you guys know. So it might glitch out, but it will pick out back up to another one. So.
Okay. Okay, I'm going to kick over to my hotspot because some guy is here working on the internet. Marissa, they must have gotten your petition.
I was just gonna say that. That worked pretty fast.
That was pretty quick there, quick at the draw. Where's my stupid? There it is. So I'm gonna kick off for a second while I transfer over. I don't see anybody's head moving or anybody saying anything. Can you hear me
now?
Yeah.
I can hear you.
Okay, thank you. All right. So the answer to this question is vitamin D. Vitamin D is fat soluble. All of your B vitamins are water soluble. So your only fat vitamins are A, D, E, K. Okay? A, D, E, K. Okay, alternative and complementary medicine. We do have to talk about this because people nowadays are becoming more interested in holistic and complementary medications, even just kind of taking over their healthcare or using it complementary. The main thing about this is that it is extremely important that you tell your patients that they need to tell you every single thing that they take, and that includes all of their herbal supplements. Okay, that is so important. There are other health enhancing practices, which I'm sure you guys have talked about, especially when it comes to pain relief. You have imagery, meditation, acupuncture, relaxation. These are very important to the NCLEX that you know about non-pharmacological things that can help your patient, okay? Categories of complementary medicine. This looks confusing to me. But you have drugs, then you have natural products, nutritional, and then you have mind and body practices, which can be physiological or physical. So there are sometimes dangerous interactions when it comes to natural and herbal therapies, and they are often labeled as dietary supplements, and you can get them over the counter, which is what makes it so dangerous. So they're not strictly regulated by the FDA. They literally say it on the bottle. They are not allowed to say that they are regulated by the FDA, and which means that the dosages and ingredients are not held to the standard that medications are held to. So it can say that it lists it as an ingredient, but you don't know what exactly the amount of that ingredient is. All you know is what it says, and they can say whatever they want. And they can be third party tested, which means that they can prove that their product contains X, Y, and Z and the amount of what it shows on the bottle. But that is expensive for a lot of companies to do. So you have to be very careful when you buy over the counter natural and herbal therapies. Okay, hold on. All right, so I want you to look at this table in the book. It's on page 1072, table 60.1. Oh no, that's vitamins. Hold on. That's not what I want. 60.3 on page 1076. It's very long. You do not need to memorize all of these. I need you to know the 4 G's. The 4 G's are garlic, ginger, ginkgo biloba, and ginseng. They are referred to as the 4 G's. So with garlic, you need to advise caution if the patient has diabetes or takes
I'm
oral
sorry, what was
anti.
the page number in the table? I totally missed it.
Page 1079, table 60.3. So garlic, it says advise caution if the patient has diabetes or takes oral anticoagulants or anti-diabetic agents. It is known to affect blood clotting, anemia reported with long-term use. Ginger, warn against use with anticoagulants. Ginkgo biloba, warn against use with anticoagulants. Ginseng, warn against use with anticoagulants. So I did tell you the other day that I wanted you to make a list of drugs that interact with St. John's wort. That is on page 1082. Serious interactions have been reported with SSRIs, MAOIs, kava, digoxin, theophylline, antiviral drugs, sympathomimetics, anti-neoplastics, hormonal contraceptives. So advise against these combinations. Okay, please look at it.
You said it was on page
Another
1082.
1082, yeah.
Okay.
Other common and this is, you know, for ATI purposes, other common ones that you should look at, just take a peek at, would be ashwagandha. That one is very common. Bless you. Um, echinacea. Kava is becoming more popular. So maybe not super important for ATI, but just like in your own education because it's becoming so popular with our generation and the new generation coming up. Can you hear me? Oh, okay.
It's
I
just
got
some of
you.
the things that you say in the transcription, it doesn't like spell them out right. So I was just wondering how
Oh,
you spelt it.
yes, that you are correct. That's why I thought maybe you couldn't hear me. Kava, Kava. And
Okay,
these
thank
are
you.
all with, you're welcome. This is all within this same table of 60.3. It's literally like 4 pages long. Another one that is common, psyllium, of course. Saffron is becoming very popular. Saw palmetto, I wouldn't be surprised if you saw that one. Soy, you have to be very careful with soy and women because of the effect that it has on estrogen. And valerian root. So those extra ones that I gave you, they are not going to be on my exam. I just don't want you to see them on your ATI and be like, whoa, I've never heard of this. I've never seen this. I don't know what this means. Okay, so just kind of skim over them, make sure you look at them. Yeah. Okay, so the patient has provided a list of herbal supplements they are taking, which should the nurse discuss in relation to the anticoagulant the patient has been prescribed?
Ashwagandha.
The answer is ashwagandha, and it may increase bleeding with anticoagulants.
The page numbers are all in our Lippincott book, right?
Yes.
Okay.
76.
Is it different? So the page numbers, because it's online versus like my actual book, it could be off a couple pages. But the tables will be listed the same. So Tashiana said it was, what was it?
1076.
1076 for St. John's Wort. So it's all within that same table.
Okay, thank you.
Oh, Aries made a good point. It says lion's mane is really popular right now and interacts with blood thinners and immunosuppressants. That's good to know. Okay, I need a break. I need to go take some Tylenol because I got a headache. Give me 10 minutes and I will be right back.